When people talk about luteal phase defects, what are they really talking about? And is there research to show that we should be worried about it? Should I be worried about it in my situation? There's so many questions to ask and so much misinformation out there on the internet that I thought it would be really helpful to clear it all up. So today you're going to meet somebody who's going to do that for you. He's a fertility specialist and a researcher, and he's going to talk about all of the subjects around luteal phase defects and more, and help you understand how to think about your fertility journey in a way that can be so helpful. I think you'll really enjoy this episode. Welcome to another episode of the Building Your Family podcast. I am so happy to have you here. There's been so much information in the news recently about luteal phase defect. So today you're going to meet somebody who's going to help you clear it all up. His name is Dr. Preston Parry, and he runs a program called Positive Steps Fertility. He's got several locations. He's got an amazing resume and also volunteers quite a bit at our professional organizations. He gives his heart, his time, and all of his wisdom so that we can grow. And today we're going to help you grow by talking about luteal phase defect because you will all need to understand it. It's really important for your family building. So welcome, Dr. Parry. So nice to have you here.
Thank you, Lisa. A privilege to join you today.
So can we start at the beginning? What is it and how do people understand how it can affect them?
So the question is not just what is it, but even does it even exist? But you're right. Come back to the definitions. And the concept of the luteal phase defect. People are saying, I'm not getting pregnant when I should. Could it be my hormones? And are my hormones not at the right levels that would maintain a pregnancy? And that's a really important question. And the problem is we both have a lot in the testing that throws off what's real. And we have a lot in what we do about it that obscures what's real. And we have different diagnoses that influence whether it's real. And how all of those things come together gets very messy. And so I'll talk a little bit about why that's so messy. By the way, for background, yes, I am a board-certified reproductive endocrinology and infertility specialist. I'm also, though, I have an MPH. So got to look at the label there, Master's Public Health. And so the average physician spends 2 to 3 days out of their med school learning how to read literature and interpret it. And that's a field called biostatistics and epidemiology. Biostats, how you crunch the numbers, epidemiology, how you analyze how people design studies. And I spent 2.5 years at Columbia doing this instead of 3 days. So I am very much a nerd for the data. And so I will talk about the limits of it a bit.
That's great. So could we start with what is it? How can we lay people understand what that means?
Yeah. And so you need progesterone to say, let's get the lining mature. You need quantity and quality. So estrogen is sort of the quantity hormone for getting the lining to grow up. And progesterone is more the quality hormone, which sort of says, when is that exact window? And if you look at just changing progesterone levels by a day for when people are doing embryo transfers, you can actually see the pregnancy rates cut in half sometimes. So really making sure that we have the right level at the right time for the right person makes a world of difference.
So how do we know that?
So the thing is, it's complex. So people don't realize this. Many hormones are pretty steady state and a solid level. A guy named Philip Corey, 1984, decided to say, how stable is progesterone really? And so he dropped a central line into people, which means he took an IV and stuck it directly into their jugular. And then he sampled their progesterone levels every 30 minutes. And what he found is while we think of progesterone as a stable, steady level, in fact, when we give shots or support, we're assuming it just lasts steady state, he found no, it isn't at all. And in fact, you can go from a progesterone of 5 at 6 a.m. to 35 by 7 a.m. So you can go from completely abnormal to completely normal in an hour.
So that means And I think this is interesting for people out there because people think, oh, I can just check my progesterone levels. But you're saying they're going to fluctuate during the day anyway. And
Yeah.
so that's a really difficult thing to do.
You can get an answer, and do you even trust it? So the first thing is, do you trust your answer? And people are all over the place depending on where they are. And so the second thing is that not only can you not necessarily trust your level, what is the negative effect? And you look at a bunch of different groups. ASRM, as you look at their guidelines on progesterone levels, from my interpretation of it, really are very skeptical about luteal phase defect. Now, again, 20 years ago, I think there was a lot more suspicion. As we get better data, we think about it more. But once it's gotten into the literature, everyone talks about with anecdote. So for anecdote, and by the way, everyone can come up with an analogy for something. I have a family friend, she's Armenian. She insists that the gender of her children, because it perfectly worked out for her life, depended on the meal she had the night before delivery. And whether she had steak or whether she had this, fish or all of this thing, they perfectly mapped out with the kids. Now, the genitals did not develop instantly in that last 24 hours, but you can't talk her out of it, even though it worked out perfect. And so similarly, for a lot of people, as they talk about progesterone, they're saying, it didn't work, and I finally did the progesterone, and now it works. The problem is you can find a study that can prove almost anything if it's small. And in fact, there's a great study from 2009, Fertility and Sterility, and they did clown therapy for IVF. And so what they did is it was in Israel, and they did embryo transfers and then randomized people to whether they had just standard transfer and recovered normally, or they got a 15-minute stand-up routine for Bozo the Clown, and they showed that there was actually a 50% higher pregnancy rate in those getting clown therapy.
Oh my gosh.
Yeah. So before you let bozos take over your care and your practice and guide it, you got to say, actually, hey, there has never been a study really convincingly proving it beyond that. It is not large or well-designed and all these types of things. So we have to look at a lot of the progesterone data being very small studies and not necessarily reliable. And I'll come back a bit to that. But what we think about is there are two reasons you're looking at progesterone. One is to say, did I ovulate? The second is, do I have enough?
To keep the pregnancy.
Right, to keep the pregnancy
going. To keep the pregnancy going.
Yeah. And so the did I ovulate group, here's the thing. And this is often your PCOS or your female athlete triads or the extremes of stress where people are not as regular with their cycles. Here's the thing. Rather than a mid-luteal progesterone, because again, you're not going to treat based on the level, wait a week. Are you pregnant? Okay, you ovulated. Did you have a period? Okay, you ovulated. And if you didn't have a period and you didn't get pregnant, then you might not have ovulated. It's really, really simple and common sense. And you don't need to be jabbed full of needles and miss work and have copays and deductibles and all those things. If you're just really trying to figure out whether you ovulated, which is also a retrospective type of thing anyway, because your window for trying to get pregnant, that had already passed. So you can actually figure out a lot of that with common sense for did I ovulate or not. And there are some rare exceptions, but most people will fall in this category, 99+%. The next question is, do I have enough progesterone? And again, if you can't fully trust even doing a blood draw. By the way, if it is high, yes, you probably do. If it is low, you might be in that window where you just got it as low, and then an hour later it'll be high. So rather, the approach is usually if you have doubt, then you treat. And that can fall into three categories. One, post-IVF. Basically, if you had, instead of the usual equilibrium of 1 egg or 2 eggs in a month, you had 25. That's a different balance. And yes, there's good data supporting the use of IVF when you have many eggs recruited. Natural cycle IVF, where you're only getting 1 or 2 eggs from back in the day, 30 years ago, completely different story. But for where we are now, really, there's very good support for using it post-IVF. Second group is primary ovarian insufficiency, premature ovarian failure, diminished ovarian reserve, where you want to. There are many names that people use. If you have few eggs left and they aren't necessarily of great quality, and they have a tendency to break down for the corpus luteum easily, it makes sense to give luteal phase support. And so many people would be comfortable using hormonal support for women in their early 40s when there is therapy rather than testing levels.
Mm-hmm.
And a final approach for it is for people who have what's called the female athlete triad, hypogonadotropic hypogonadism, and that's the fancy name. But hypogonadotropic means low activity from the brain to signal to the ovary, hypogonadism, low activity of the ovary. So if you have low signal from the brain to low activity of the ovary, you may need a little bit of support just because it's not making the progesterone the usual way. Those are sort of the core three categories. And it's not to say that they can't be exception, but the likelihood you are that 1 in 1,000 individual, and people can argue the numbers, but the likelihood you're that, and that's your source, pretty low.
Well, that's very interesting. I have a few questions about that. And
Sure.
I think people wonder, and certainly the patients that I see are very stressed. And I'm sure the patients you see are stressed as well.
Yeah.
But they come to me and will say things like, well, if there's no downside, like you just mentioned, if you're concerned about your egg quality, maybe you want to go the extra mile. But lots of people would argue, well, I am spending a lot on treatment, or I have a gestational carrier that I'm spending a fortune to, or I'm so stressed out, I don't want to go through one more cycle. Why not just throw everything at it? If we can use some extra progesterone, why not? I'm so
Yeah.
afraid that I'm not going to be able to maintain, because for those of you who didn't just get this, if you have the right amount of progesterone, it helps to maintain the pregnancy, right? And so people are so nervous. What's going to happen if I don't do that?
So many things to talk on that, and redirect me if I start getting on tangents for
That's
things.
fine.
But by the way, for stress, there was a wonderful study from about 20 years ago that actually showed the most stressed people actually were the ones who got pregnant. The laissez-faire people were like, it'll happen when it happened. No, the stressed people took charge and they actually acted on things, and you saw a better outcome. So,
Wow.
well, for all your anxiety, you care about the outcome. This is personal,
Yes.
it's existential. And the fact that you're focused laser like on getting where you want to be, that can be a better thing than you want. In fact, if you look to stress, look at birth rates during the Holocaust. You look at Angola under periods of genocide, or Eastern Europe under economic transition. Almost in periods without contraception and not deliberate choice, almost no change in the pregnancy rate. And
Yes.
so there are all kinds of things to unpack with that. And
True.
stress, you often look at it 3 points for how it's impacted. And you can talk more fancy explanations, cortisol levels and all kinds of things. But here's the thing: preconception, at conception, post conception. Preconception, you're so stressed you don't ovulate. If you're not releasing an egg, it's hard to get pregnant. But if you are giving medication to make sure the egg grows, you're looking at an ultrasound that it did grow, you're giving HCG as a trigger to see that it released, you got eggs. So that's preconception. At conception, you end up, basically people fight with each other when they're stressed, and then they stop having sex. And if there's no sperm in the reproductive tract, hard to get pregnant. Well,
Right.
you're doing therapy, IUI, IVF, whatever, sperm found the egg. Post-conception, back to where I was talking, the hypogonadotropic hypogonadism. But if you're giving the hormonal support to offset that, then people do well. You can take people with what's called transsphenoidal resection of a macroadenoma. They had a brain growth in the pituitary. They remove the entire pituitary. So they've got, never mind low levels, they've got no levels. They've got no signaling. You give them the progesterone and they get pregnant very well once you've generated the eggs or the embryos. So that was a complete tangent off of your original question. I think what was the original question do we have here?
Well, first of all, that's very interesting. And I completely agree with you. There are people who get pregnant under all kinds of stress, right? So unfortunately, people who get raped also can get pregnant, right? And so it's really a difficult situation to feel like, well, I'm stressed about being stressed. So I think a lot of patients will say, okay, if I'm having trouble ovulating, I just need more hormones. If I'm having trouble conceiving or making embryos, well, then I do IVF. But this last part of progesterone, yes or no, the patients are thinking, well, why not do this? Because then I'm covering my bases, right?
Yeah,
I don't have to worry about paying my gestational carrier for another transfer. I don't have to worry about hopefully having to go through this again, or even emotionally, I can't tolerate
right.
it anymore.
Well, so a gestational carrier would always get hormonal support because that's post IVF for things. And so that's very important on that level. And so I think it distinguishes really, you're talking natural conception or IUI when you debate the progesterone. IVF, egg donation, gestational carriers, all that, that's automatic progesterone. And I think when you're choosing an intervention, you have to say, what is my cost? What is my benefit? And when you look for a lot of the natural conception where they can't always prove, or in most cases, that it's relevant, are there downsides to progesterone support? And the shots are painful. The
Yes.
suppositories are messy. They add cost without necessarily clearly changing the outcomes. A lot of the studies showing benefit actually were really small sample sizes. And there's a lot of debate as to whether it made the difference. And the thing is, people don't often talk about that, but there's a risk of birth defects. So when you look at getting progesterone support, often you see normally for spontaneous, there's 1 in 2 out of 10,000 babies will be born with hypospadias. It's a downward turning of the male penis. If you are giving progesterone support, you can see some data suggesting this gets up to 4 in 10,000. So if you're adding cost, it hurts or it's messy, it doesn't necessarily help because you're not necessarily in one of those categories where it's more well established, and you can have birth defect risks. It is very reasonable to say, hey, maybe this isn't the right fit. But as you get into categories, again, IVF, egg donation, gestational carrier, that's automatic. But for these other categories, there is flexibility. And that's back to the core thing that I'm trying to emphasize, both for do you need to take progesterone as well as getting to the stress? If the benefit is really small, there are some downsides, and it's probably not the source. There's a lot of flexibility in not doing it. Similarly, for the stress thing, people, as you alluded to, they're stressed and then they're stressed about the stress, and it's a vicious cycle. And the ability to say, no, this is probably not the source. We got this covered because we're getting your eggs, making sure sperm find them, and then giving hormonal support if indicated. Most likely people are doing well. And I think people need to hear that to take some of this burden off their shoulders.
Yes. That there is an answer for them.
Or to even rephrase,
Yeah.
we may not have the perfect answer. We need better data. But we can say most likely. Remember, most of our decisions as humans are in the 60 to 80% knowledge. We don't know everything, but we say, best shot. Or as a doc, what would you do for your own spouse? And we can say, pretty much we've got most of where we need to go on this, even though there's flexibility.
So that's very helpful for everybody out there to think about that we don't really need to worry about that in IVF, but in IUI, and also if you're getting pregnant at home or trying to get pregnant at home or even using a midwife, then you have to kind of think about these things. So there are some downsides that you're sharing. And what about the person who's trying to get pregnant and they haven't seen a fertility specialist yet and they don't know what's wrong?
So one of the questions is, if I just give myself progesterone, I'm trying at home, old fashioned way or with an OB who's just minimalist in body things. Remember, it's not just the level. It's actually the timing, which is the truly critical thing for when things are there and supportive. And if you take it too early, you can throw off the lining, or too late and it doesn't make a difference. Remember, the very first contraceptive for birth control pills were a yam-based progesterone.
Really?
And so, yeah, back in the 19th, Desirati, all the people back, with the earliest things where they were extracting it. And remember, you talk about Plan B, that is a progesterone. You talk about, the not just the morning after pill, but there are also progesterone-only contraceptives on the market. So you could actually be making yourself worse. There was a great study
Wow.
out in the Netherlands that actually was saying, okay, you can do whatever you want for holistic and naturopathic therapy and everything. And you don't tell your doctor, let's just see how this plays out. And they showed 40 to 60% lower pregnancy rates. It's not that they can't do better. It's that you're more likely to do worse than better with a lot of approaches, and people don't realize this. And the challenge is then, boy, I didn't get great advice from my friends. My body is not behaving itself. I've gone to a clinician or I've gone to Dr. Google or TikTok and it didn't have an answer. And people get progressively more discouraged and disappointed because their therapies aren't getting the result when they actually don't have a diagnosis. One of the critical things I think is most people don't have good evaluation or effective treatment. And I see people all the time and they've been told, oh, you just have to relax or take a vacation. And they've got polyps in the uterus.
Yeah.
You've got to lose 30 pounds, but they have blocked tubes, or they're saying, oh, you need to have the perfect nutrition and sleep patterns. And the husband is firing blanks. And so the reality is having the proper evaluation, if you're channeling your things into the wrong place, makes a world of difference.
Yeah, you're so right. And it's, such a difficult problem we have now because people will take advice from TikTok or from, their yoga specialist and say, well, that's what I need to do. I need more meditation, or I need to eat these pineapples or supplements or whatever it is. And they'll do that instead of having an evaluation.
Right.
And we see so many people do that. They feel like the more natural way is the better way. And yet, if they needed chemotherapy or even glasses, they wouldn't say, let's just be natural about it, right? And so, for some reason in our culture, we feel like this should happen easily. And how do you suggest that people understand that so that they can come in and have a workup so they know, if they're a lesbian couple, it's not just about getting sperm.
Right.
As you said, they may have blocked tubes.
Yeah.
So, how do patients think about their family building journey from the time that they say, okay, I want to start building my family?
Well, I think it has to be individualized. You need compassionate, educated care. And the average OBGYN, by the way, this is silly to point out, but I've looked at multiple residencies, and the amount of time the OBGYN spent in a residency on an infertility in a clinic is often 0.1, 0.2% of their hours in training. They've had minimal training.
Yeah.
I would say people are good at what they do. I look the hood of my car. I can't find spark plugs. I don't look there,
Right.
That's just not what they do. And so most OBGYNs, bless them, but they haven't spent a lot of time on infertility. It's not that there can't be good pockets, but there's a lot of variability as to who really knows what they're talking about. Again, I haven't done a pap smear in 15 years. I have not, done a delivery in probably a similar amount of time. I wouldn't try to do that. But we think we have to be masters of everything, and we aren't.
Right. Exactly. And we wouldn't, if we had to go for heart surgery, we wouldn't say, well, try our yoga specialist for that, right? I mean,
Exactly. But the reason is that fertility has been put into this thing where it can happen naturally and be cured naturally, when often it was people who were just very low chances, but they got lucky. Everyone tries to make this black and white, all or nothing. I used to say there are a lot of shades of gray now with the movie and the books. It's a little bit different. Can't use that as much. But the point is, there's nuance. And people who have the worst odds can get lucky. People with incredible odds can be unlucky.
Yes.
And you have to rather understand what's beneath to leverage things as much as possible in people's favor.
Imagine your beautiful future. You're snuggling with your child. You feel so connected to them. Your friends and family are so happy, and you have everything that you've ever wanted. I want this for you too, but I want more than that. I want you to feel secure knowing that you've made the best decisions, not just short-term, but long-term for your future family. Wherever you are on your journey, whether you're choosing a donor, choosing a clinic, learning how to talk to your donor-conceived child about their origins, all of these decisions will have wider implications for your future. And I want you to have the right resources so you can feel empowered and confident at this very important time in your life. That's why I'm so excited to introduce you to Building Your Family. It's the only expert-guided platform designed for parents and parents-to-be using reproductive medicine. We provide unique strategies that you won't find anywhere else to make your path to parenthood smoother and more informed. And that's why our approach is about offering practical and actionable steps that you can use right now. Whether you're just starting out or already deep into your process, Building Your Family is here to guide you with expert advice, specialized education, stress reduction strategies, and a community to support you every step of the way. We can't wait to see you inside. So what would you recommend to people? Because when we talk about the luteal phase and patients get nervous about, well, am I going to maintain this pregnancy I'm working so hard to get?
Yeah.
How should they be thinking about? I know that originally we were thinking with ASRM, people should have a year of unprotected sex, right? And that's very difficult, certainly, to deal with a year. And also for people who are not in heterosexual relationships, that's very expensive.
Yeah. Well, so several things on that. So first, as you say, hey, where is my progesterone? What's going on for this? We have to step back and say, why do things not go forward and how it ties into progesterone? First of all, remember when people talk about a pregnancy that doesn't go forward and has low progesterone, that's the symptom. It's not the source. The pregnancy was already failing. And most pregnancies that don't go forward, actually, it's because there's chromosomal abnormalities. It does not matter how much progesterone you give. You can't change the DNA of the embryo with a progesterone. And so people are doing that. And there's so much we try to attribute to it when they're different sources. And most of what we're seeing and shifting for the field for both testing as well as recurrent pregnancy loss, a little more support and some debate for progesterone support with recurrent pregnancy loss, but certainly for fertility. Here's a statistic most people don't know. If you are 30, 18 months unprotected sex, what's your chance of being pregnant? That's a pretty basic question. Hey, it hasn't worked. What are my odds?
Right.
30-year-old with 18 months is running a 2% chance per month of spontaneous pregnancy leading to a live birth. That's it. And that's based on the North life tables and choice. You look at population data. For those who are going to get pregnant, about 75, 80% of those who will do it within 3 months, 90% by a year, almost 98% of those who will do it over several years did so within that first 18 months. So the fact is, when there are so many other sources, how much are we attributing to progesterone when that's usually not the thing? We overcomplicate fertility, but it really boils down to four things. Got to have sperm, got to have eggs, they've got to meet in the tubes and have a place to go in the uterus. If you cover those four bases, you've covered most of that which matters for fertility. And the progesterone is just incidental. That's so far downstream. And usually it relates more to those who aren't releasing eggs or have very poor quality as a result of age or chemotherapy or other things like that.
Well, what about all these people who worry about their lining, right? They're back and forth to the doctor. My lining's not thick enough. It's not thick enough. I have all these problems. What do you say to them?
So I would say, first of all, everyone wants everything to be perfect. I want everything to be perfect. And I see a thin lining, it makes me nervous. But we also have to say, where does the data come from? And then why is it an issue? And then we're actually moving away from the thin lining as a concept a bit more. Remember, people can get ectopics. The pregnancy is growing in the tube. There is no lining.
It's true.
And so actually the origins of the thin lining go back to a study by Buster and Carson out of Baylor in the early 1980s. And it was about 30 patients. And they said, hey, if you were above 7, people got pregnant. If it was below 7, they didn't. That's where it came from. But remember, you got 15 people per arm or just very few people in it. And the pregnancy rates were 20% or lower per person back then. You have such small numbers, people can't really conclude it. But that was the number that got into our consciousness and then stuck. So what I would say is it's less about the thickness of the lining. To my understanding, and I know there are other people who believe differently, but I would say it's rather why it's. In epidemiology terms, it's called confounding by reason by indication. The reason for an outcome isn't that you were something, it's why you were. And so for a lot of people where that's thin lining, well, if you're an ovarian failure and you aren't making estrogen, then it's the low estrogen relating to poor eggs that was the cause of the thin lining, not that the lining was thin. If it's because you have recurrent pregnancy loss, and people have scraped away much of the lining, so there's very little there remaining for an embryo to attach to. It was the fact that it got scraped away, not necessarily its technical thickness. If it is also, you have recurrent pregnancy loss and people have scraped it away, but it was also the fact that you had imbalanced translocation, you had lupus, you had other things causing this recurrent pregnancy loss
Mhm.
that led to these going. That's the source more than the lining itself. So we have to ask, again, not just what is there, but the why. And if we don't understand, we're ineffective in how we act.
Yes, I've wondered that too. How can we have an ectopic pregnancy and
Yeah.
yet worry about the lining, and yet there's still this kind of hard and fast rule at most programs that you have to have a certain lining to go forward with the transfer, right? And same with gestational carriers, they don't get cleared if they can't make a lining either.
But to throw something out there, have they convincingly proved that going longer with estrogen or any other therapy convincingly improves the pregnancy rate? No. And so we go longer, but we're treating our hearts rather than our heads. And the data does not convincingly show that there are better outcomes from my familiarity with things. And I agree this is art. Everything I'm saying, I believe knowledge can evolve, people's perspectives can. But from what I see of the literature, there's a huge difference between what's technically significant and clinically meaningful.
Yes.
And if you go from 1 in 1,000 to 1.1 in 1,000, people will say, "Oh, that's an improvement." If you had a large study, it still didn't change the fact that you're running 1 versus 1.1 in 1,000. And so we have to really talk about how much of a difference some of these other issues that people talk about really make or mean.
Yes. So I think that that takes us back to the quality of the eggs as people,
Yeah,
understand but hate to understand that we can accept that our hair gets gray,
yeah.
but our eggs are just going to get old. And I hesitate saying that because I know people don't like to hear it. But ultimately, I guess we're always going back to that being the source of the most difficulty.
And it's an unpopular thing that you're born with all your eggs and you ovulate your best ones first. It's sort of like a game of telephone. You're 2 people down the line, you get the message, you're 20 people down the line. You have no idea what the first person said. The eggs you ovulate earliest in life are those earliest generation copies and are less likely to have those issues. And that's
Yeah.
why you have a lower rate of Down syndrome and miscarriage in your 20s as you do in your 40s. But that's just the biology.
Yes, and so that leads us back to the importance of early treatment, or at least an early assessment,
Yeah.
even if they have not decided to pursue treatment yet. At least check out everything that they can. Take a look at the tubes, at your cavity, at
Mhm.
everything that you can. And so at least you have some idea of what's happening and not waste time.
This was the core conclusion of the Hardest conference in Rome, which was April of 24. It was the first, I would say, that I'm aware of, the global congress dedicated to why do chromosomally normal embryos not implant? So the acronym came from H for hysteroscopy, ART for IVF, and US for ultrasound. And what they said is about 66, this was sort of like an unofficial but sort of group consensus. It was about 65% is embryo, about 35% is uterus, and about 10% other things. And you're talking weighing 300 pounds of lupus and cancer and AIDS and all those types of things. But most of it, it's the embryo and the uterus. It's the resident and the home. It's the passenger and the vehicle. And if you
Mhm.
focus on those, you are going to cover most of that which matters for embryo transfer and IVF for success.
Yes, it's the embryo in the home, but you have that home, and that's I guess going back to what we were talking about before, and you're saying that that's secondary in many ways.
Well, I would say that it is a large part of things. To say that one thing is 60% and one's 35% or something roughly on that scale, that's still, those are huge areas to focus on. And I think I see routinely things that have been missed. And I find, oh, you have, people say you have a normal uterus. No, you had endometritis as a chronic infection. No, you have polyps. Had people say, oh, your tube is blocked. And what they found is the person had a septate uterus and they only were looking at one half of the uterus when they didn't see the other two open.
Mm.
Or you can find infections or retained placenta or all these types of things. And I think one of the key issues is so many people are told they are normal when they aren't necessarily.
Yeah, there could be endometriosis, PCOS, all sorts of things that people don't that silently can cause problems.
Yeah.
And so when you see patients, Dr. Perry, and you're explaining this to them, I'm assuming it's difficult to be in this situation where, they're hearing all of these things on the internet and they want more luteal phase support. And maybe that's not the right answer for them. Maybe they just need to keep going.
Well, I think you have to find the right solution for the right person. But we're very big believers in sort of quick, efficient, accurate testing. And so in 10, 15 minutes, I can do an ultrasound coupled with a hysteroscopy, and I can figure out most of the female factors. If you're looking at ultrasound for antral follicle count as gold standard for ovarian reserve, you also pick up endometriomas, other issues. You look at ultrasound plus hysteroscopy for the gold standard for the uterus, ultrasound for outer uterus, hysteroscopy for the inner uterus. And then we also use air-infused saline to assess whether the tubes are open during our hysteroscopy. You're looking at most of the female variables picked up in a single 15-minute visit. And it's accurate, gentle, safe, all the core things that we're looking for. This is a very reasonable approach. And if you can get quick answers with one visit, why don't you?
I agree 100%. I'm just wondering also for some of the other people out there who come in to you or their own fertility doctor and say, I tried to get pregnant at home and I felt like everything was fine and my pregnancy test looked good, on the little stick. And yet I'm spotting, I'm having trouble, I'm feeling all these weird feelings. I don't know what this means. Am I pregnant? Am I not pregnant? What's happening in there? What are patients feeling in that second stage?
There are so many things going on. One is sort of existential questions, for where I am, what my family is generating. And the other is ultimately the relationship. And what am I feeling in my terms of trust? Will this person help me to the best of their ability? And those are completely valid and important and complex balances. I always say, you know what? People want to know how much you care before they care how much you know. And I think you have to be with the right person to
Yes.
get effective counseling. And so you really say, hey, what are your success rates? What do you see for me? What are you going to do about it? Is it effective? Is it fast? Is it affordable? Is it gentle? And what are my odds? When I talk with people, I say, look, we're doing one test to figure out where you are. And then I think, 3 rounds of pills and insemination. We do that right now for about $1,600 total. A lot of people are getting an IUI for $1,600 for one round. We're doing that for 3.
Wow.
And if you're doing that, and you're saying, look, I often see if we've got open tubes and all the right building blocks, about 30, 40% of people being pregnant within 3 months, rather than worry about all the things it could be that people debate whether are even irrelevant, all the Geritol and Robitussin and pineapple core and hips in the air and boxers instead of being salty McDonald's French fries. Let's put that aside. Let's just say, hey, we're going to do a test, one test, and then let's give it 3 months. And 30, 40% it doesn't work. Or it works, and 60, 70 it doesn't. But that's putting an expiration date on an approach to say what's reasonable. And if you've compartmentalized the problem rather than saying, well, what if, let's just put a short time window on this and see what we can do. A lot of people do very well. And also, even if they haven't, you've gotten a lot of answers along the way.
That's great. It's so helpful to think about it that way. I think if people are starting to think about that in kind of phases, as you're saying, and putting time limits on it, it can be so helpful for them emotionally because then you just digest one part at a time.
Yes, absolutely agree.
And what about for people who are using gestational carriers and they say, well, I want my friend to carry for me, and maybe their doctor's saying, well, her lining's not thick enough, but she wants to do it anyway.
First of all, I always say you're not going to teach the Leonardo da Vinci of endometrial thickness to paint with a different brush. People have their comfort zones, and you have to work with the building blocks you have rather than necessarily the ones you want. But I would also say the ability to say, hey, they're going with their comfort zone. They've been practicing a while. That you give a little bit of leeway for how they choose to paint. But at the same time, if you have to acknowledge limits to data and the ability to say, hey, the data isn't that strong on this. Maybe I shouldn't worry about it as much, because if it were really and truly meaningful and detrimental, then the data probably would be more clear.
It's a very good point. Excellent. You're so insightful, Dr. Parry. I really appreciate your insight. It's amazing.
You're too kind. Thank you. Yes.
Since you're talking about patient care, it might be a good time to talk about the importance of your invention, the periscope.
Just for context, so 10 years ago, we presented this at ASRM in 2015. It was the first global congress anywhere where someone had presented how to look inside the tubes hysteroscopically with air bubbles. And so what we said is here, and I'll go on a tangent a little bit with it.
Go ahead.
I had a mentor who was insisting on sonosalpingiography for air-infused saline. And there was a lot of data that it can hurt as much as HSG. And some people say it's gentle, but it's very interesting that the approach that's gentle isn't as accurate, and the approach that's accurate isn't as gentle. So there's some issues there for it, though there's some people who can do hyphosi very well. But anyway, he was insisting on it being done, and I hated it. Honestly, for the approach, I've done it for years, and I was just always worried about tubes and things like that. And I'm like, oh my gosh, I have to come up with something that's more gentle for people, that still gets me where I want to be. And I realized I was doing hysteroscopy. So we published our pain data in 2017 in fertility and sterility, and we showed that we could do hysteroscopy, diagnostic hysteroscopy, where 91% of people had mild to no discomfort. We're taking fiber optic cameras, the dimension of a coffee straw. It's small enough to go in the male bladder in the office without anesthesia. I always say, if it can go in the guy's anatomy,
wow,
women can probably handle it pretty well. Well, the fact that you're saying that this isn't ubiquitous drives me crazy, because it should be. ENT, we view nasal endoscopy as inseparable from the physical exam. Urology, 98% of urologists can do small caliber cystoscopy to look in the male bladder in the office without anesthesia. Fewer than 20% of OBGYNs will perform office hysteroscopy, and often many people estimate it's in the 10-15% doing it routinely, and probably in the 1% using instruments as small as urologists. Women actually get less accurate, more painful care as a result of disparities in access. And if we are saying, look, let's just take the instruments that urology would use them for women. I actually go a little differently. I use neurosurgical endoscopes and cholecystoscopes. I'm saying, let's get super small cameras that are very highly accurate. You can do a hysteroscopy in the office. We showed in the study it was, averaging under 5 minutes. We can go faster than that at 3 and 2. I mean, it's even under 1. And we've been gold standard for the uterine cavity. We're even able to assess tubal patency while we're there through air infusion and watching the disbursement. That paper was in JMEG, Journal of Minimally Invasive Gynecology 2017 by us as well.
Wow.
And you're saying, look, it's 2-3 minutes for many people. You got your tubes evaluated. You find all kinds of things in the uterus that people miss. Most people, it's less than a pap smear or comparable. And you figured out a lot. And at gentle, accurate, safe, fast, these are things that matter. And so we're due for a paradigm revolution in how we do fertility testing. So we called it the periscope technique, just for a tangent, since I tend to do those.
Why not?
The original research was hysteroscopic assessment of fallopian tubal patency. That's what we called it. And everyone said that's too wordy, you got to abbreviate it. And this was all kinds of research and stuff. And then we try to make it into an acronym. And we find that hysteroscopic assessment of fallopian tubal patency makes the acronym HAF-to-P. And we're like,
goodness.
we have no idea. And, we're like, we're not urologists, this sounds horrible. So we got to come up with something better. And we said, well, we're looking in the uterus underwater, and I'm Dr. Parry, and periscope kind of just worked for a name. And so we started using it, and that's kind of how the technique that we invented has come to be known. But regardless of what you call it, the reality is there's a paradigm where we can be more gentle in how we evaluate the uterus. And if you think of sonosalpingiography, where you're infusing air bubbles to see the tubes under ultrasound, we're just doing it with a fiber optic camera, looking at directly where the tubes are released. And we can find a lot about the bubbles by how we do that, as well as find things within the uterus that can often be missed with ultrasound. We're getting a lot of knowledge, and it's gentle. You're using saline you get in the body through IV fluids. You're actually using less air than with sonosalpingiography. And you find things. And it makes that a paradigm shift for how we test people matters.
It's incredible. So for those of you who are missing a little bit of this, I think it's really important just to highlight the fact that we all who go through IVF, or most of us anyway, need to have this test, right? The hysterosalpingogram, or you have a hysteroscopy. There's some way that your doctor needs to look inside of your body and make sure everything's functioning well, but it's pretty painful.
But I can't tell you how many times I've seen people where they failed the embryo transfers elsewhere. You look inside and you just find so much pathology, and then they've been told that they were normal in ultrasound, and the
Wow.
hysteroscopy almost instantly picks it up. But also, even some people where they're told they're normal with low tech hysteroscopy, there are low resolution hysteroscopes out there, and the high resolution help. And especially for endometritis, which is an evolving concept for the level of a low level of infection that 15 to 20% of women may have. And you can see some data even saying the difference between women who are successfully treated for endometritis and those who weren't, who had it and it was not effectively treated. There's a six-fold difference in their pregnancy rates.
Wow.
And so, and this is something we published this in the American Journal of Obstetrics and Gynecology earlier this year, showing that actually just by looking in the uterus, you can pick up most endometritis. And if you don't see it, most likely it's not there.
That's incredible. Are you able to see as much scar tissue as you would in like a laparoscopic surgery?
Well, the thing is, so laparoscopy and hysteroscopy are different things. So laparoscopy, you're looking outside the uterus for scarring, and hysteroscopy, you're looking inside the uterus.
Mm-hmm.
Laparoscopy, incisions through the belly button. Hysteroscopy, you're just going through the cervix, so you're not making any incisions to do so. The truth of that is, for a lot of people, especially with IVF, you actually are, really focused on inside the uterus, back to the resident in the home, the passenger in the vehicle. Really, that's far more important than what goes on the outside, though there can be some exceptions for that. And
Yeah.
so if you can gently figure it out in the office, rather than surgeries and anesthesia and $10,000 and with deductibles and copays,
Yes.
that, just look inside gently.
This is such great information, Dr. Perry. I really appreciate your time. Are there things that patients are curious about, or that you find that your patients are curious about, that we haven't covered today?
I think there are so many things, and I'd love to talk again, on other things. I think we have a long list for which people are finding fringe or small studies suggesting a difference, or common sense doesn't always overlap with the evidence. And I think we
Yeah.
have to talk as valuable as any nuance for intervention. We have to say how much it matters. Because remember, there's so many variables that go into fertility, it's hard to prove that any single one matters. In fact, some of the best data actually show that testing for ovarian reserve doesn't matter for fertility outcomes. And the reason is not many, but some people obviously do, but few people have ovarian failure as they're first starting to try to conceive. And so obviously, if you have very few eggs, that matters. But if the studies can't show that makes a difference, that we have to talk about what we do when individual problems can be relevant, but may not fall within the domain of statistics. So it's not just the treatment, but how do we even think about the problems and how we tackle them?
That's very interesting. And I think there's a lot of, we should talk again, absolutely, because there's a lot of misconception about how to understand your fertility. Many people think that you can look at an egg and understand its composition. And of course, we're not there yet, right? So people feel like, well, I can look at my eggs. I have a bunch of eggs. They look like they're okay, so I'm going to be fine. And that can be really difficult for patients because they don't see that they have to wait to see that there's proof in the pudding, right? We have to see the embryo to get even a
Yeah,
sense. And so that's a really interesting topic, which we will absolutely need to talk about next time. So we'll have to do part two, Dr. Perry.
I'm game for it at any point.
Okay, great. And in the meantime, can we tell people how they can find you?
Just Dr. Preston Parry, Positive Steps Fertility. You can also, Google Periscope, Parryscope. And we've got all kinds of videos on YouTube and Facebook and Instagram and TikTok and our webpage. And by the way, none of this is a solicitation for services, and all of this is, general medical information. I'm not diagnosing any individual as we talk about that. And medicine can evolve. So my positions and views if we have new studies, I will adjust with them. but I'm saying for how I see the world. This is one of the things. There's a lot of facts out there, but the value is actually in the perspective, how you assemble the facts, and then ultimately see how that lens personally applies to you. I think there's a lot we have to think about and even rethink how we've been classically taught and what we communicate for fertility. But fortunately, Lisa, you do such a good job in educating people. I tell you, there are many people who should be turning to you rather than some of the books. You do a great job. I've loved all the stuff you've done over the years. It's a lot of respect and appreciation.
Oh, thank you so much. And I really appreciate you coming, and I look forward to the next time when you're back. And for all of you out there, thank you so much for coming. I also want to ask you a favor before we close. If you are not a subscriber, and many of you have said you didn't know you weren't subscribers. So if you're not a subscriber, please, before you end, just press the subscribe button, because that's how we keep going. And I really appreciate your time. Thank you. And reach out to Dr. Parry, because obviously you can see he's very willing to answer your questions and be there for you, as he is from so many of his patients. So thanks again, and I will see you next week. Thank you for joining me today. I hope this was helpful to you. And if you'd like more personalized support, more information, and more education, you can find it in the show notes under the Building Your Family community. We'd love to see you inside. And if you were interested in today's topic, you will really like this video.